Good afternoon. I'd like to thank the SAGES Committee for the privilege of the podium today. I have no relevant disclosures to this work. Laparoscopic paraesophageal hernia repair achieves high rates of symptom resolution. However, long-term studies have recently reported as many as half will have a radiologic recurrence. Inadequate closure of the hiatal defect is the leading cause of post-op reherniation, with risk factors including a wide hiatal defect and large hernia size. To help reduce excess tension on the hiatal closure, adjunct techniques such as use of mesh as well as relaxing incisions have been described. Additionally, in comorbid patients presenting with a volvulus, anterior gastropexy with or without a gastrostomy tube has been described as a salvage maneuver. A giant or massive paraesophageal hernia is technically challenging, and optimal repair techniques remain widely debated, including the role of mesh in reducing recurrence. However, the correlation between hernia sac volume and operative repair techniques remains poorly understood, as the hernia size is difficult to quantify and often not accounted for in many studies. Although it's unable to be assessed using standard preoperative studies such as upper GI and EGD, there has been increasing recognition of esophageal hiatus size as a significant risk factor for recurrence. Granderath et al. Described a method to assess the hiatal size during surgery using intraoperative measurements of radius and angle to calculate the hiatal surface area. Using this technique, several have proposed tailoring their repairs based on measured defect size. However, this technique assumes a hiatus shape that configures to the geometric formula and can be limited by distorted anatomy from insufflation, paralysis of the diaphragm muscles, and surgical dissection. Thus, our study utilized computerized volumetric analysis and a multiplanar reconstruction technique to measure the hiatal defect area and intrathoracic hernia sac volume and compared these measurements to operative findings and surgical techniques performed. An institutional hernia-specific database was queried for all patients who underwent a paraesophageal hernia repair and had an abdominal or thoracic CT scan that adequately visualized the entire extent of the hernia sac and crural defect. Perioperative data was collected in all patients, including CT measurements of the hiatal defect area and hernia sac volume, which were measured using volumetric analysis software, and then used to predict the likelihood of intraoperative variables. Multidimensional rotation of CT images allowed for visualization of the entire hiatal defect in a single axial plane, mimicking the surgeon's view during repair. First, a sagittal image that visualized the esophageal hiatus including anterior and posterior margins was identified. The line representing the axial plane was rotated to intersect both the anterior and posterior hiatus margins. In doing so, the oblique orientation of the coronal plane is now parallel to the distal esophagus as it crosses the hiatus and mimics the surgeon's axis when viewing the hiatus with the patient positioned in reverse Trendelenburg. The coronal images were then reviewed to identify an image that showed both the right and left crura of the esophageal hiatus, and again, the line representing the axial plane is rotated to intersect both the right and left crus. The doubly oblique oriented axial plane is now oriented in the plane of the esophageal hiatus, allowing for accurate measurement of the defect area in a single cross-sectional image. A polygon tool was then used to manually outline the inner margin of the hiatus, producing a measured hiatal defect surface area, or HDA. To obtain measurements of the hernia sac volume, the entire intrathoracic hernia sac was manually outlined on multiple sequential axial images, which automatically produced a volume measurement based on a summation of exact area dimensions. Our study included 213 patients with preoperative CT scans who met inclusion criteria. Our study population had a high proportion of elderly obese patients with a mean age of 66 years and a mean BMI of 29. Most patients were female, had comorbidities including hypertension, and were either ASA class 2 or 3. The majority of patients presented with typical symptoms and were on a PPI, and 18% of patients presented following a previously failed paraesophageal hernia repair. Type 3 was the most common type of paraesophageal hernia in 63%, while nearly 25% had herniation of other intra-abdominal organs. Surgery was performed emergently in 14% of patients, and gastric volvulus was present in 18%. Aside from the stomach, the most commonly herniated contents included colon and omentum. A minimally invasive approach was used in all patients. However, 1.9% of patients required a conversion to open. Primary cruroplasty was performed in nearly 90% of cases, and 65% of patients had a fundoplication, most commonly a toupee. Mesh was used for crural reinforcement in 58%, while 4% required a relaxing incision of the diaphragm, and only 4 patients with insufficient esophageal length required a collis gastroplasty. Finally, a salvage gastropexy was performed in 11% of patients. The overall median hiatal defect area measured on pre-op CT was 25.7 centimeters squared, and median hernia sac volume was 365 centimeters cubed. When looking at the size of the hiatal defect in relation to operative findings, median HDA was significantly larger in patients presenting emergently or with a gastric volvulus. Compared to patients with a defect area below the median of 25, 22% and 28% of patients with HDA greater than the median presented with an emergent repair or volvulus, respectively. A larger median defect was also noted in patients in whom primary cruroplasty was unable to be performed or that required a relaxing incision. In patients with a defect size above the median HDA, significantly fewer had a primary cruroplasty in 84%, while more required a relaxing incision in nearly 9%. No significant differences in median defect area or percent of patients requiring mesh, fundoplication, or collis were observed. Increased hernia sac volume on CT significantly correlated with patients requiring emergent repair or presenting with gastric volvulus, and similarly, patients with a hernia volume larger than the median had significantly higher rates of requiring emergent repair or gastric volvulus. A similar correlation was seen in patients with large median hernia sac volume and requiring either a primary cruroplasty or relaxing incision. In patients with a hernia sac volume greater than the median, only 83% had a primary cruroplasty performed, while 8% required a relaxing incision. No differences were noted in patients with mesh or collis. However, fundoplication was correlated with a smaller median hernia sac volume. Using hiatal defect to predict the likelihood of intraoperative events, we found that a 5-centimeter increase in hiatal defect area was associated with 27% greater likelihood of requiring an emergent repair or presenting with a gastric volvulus. Each additional 5-centimeter increase in hernia defect area also increased likelihood of salvage gastropexy and relaxing incision by 13 and 43%. An increase in hernia sac volume by 100 centimeters cubed also increased the likelihood of needing an emergent repair, as well as likelihood of incarceration or volvulus. Conversely, we saw that increases in hernia sac volume were a negative predictor for primary cruroplasty as well as fundoplication. As a result, need for salvage gastropexy and relaxing incision were both nearly 1.2 times more likely with each additional 100 centimeter increase in hernia sac volume. In conclusion, CT volumetric measurements correlate with a predicted need for interventions, allowing the surgeon to anticipate complexity of repair and operative approach. In patients with a paraesophageal hernia, incremental increases in hiatal defect area and hernia sac volume are associated with emergent presentation that may require complex repair techniques such as diaphragmatic relaxing incision or salvage maneuvers. Further study is required to assess whether CT imaging should be a standard radiographic modality when evaluating patients for paraesophageal hernia repair. However, our study demonstrates that it may be a valuable adjunct in preoperative planning. Thank you very much.